Please join me to welcome Professor Kenneth Kwing to
Thank you, Doctor, for the very kind introduction. It's flattering. I don't know who wrote that CV or not, but anyhow, very thankful for that. And also like to thank the organizer for this invitation. This is my second year to speak at the NCCM, and it's always my pleasure to be here. The next topic, I'm going to move away from psychology, love and care, which are absolutely essential elements in life, we have to admit. I'm going to move to something that is more practical, and that is the dollar sign. So, we are like jumping from one world to another. Okay, so the topic of my presentation is health economics of cancer care in Malaysia. Okay, this is the overall content of my presentation over the next 20 minutes or so. Health economics of cancer care is a huge area, but essentially it can be roughly categorized into 4 big areas, namely accessibility, affordability, equity, and sustainability. Now, I've been only given 20 minutes. So if I were to go through all 4 areas of them, I need another 2 days. So I just going to concentrate on one point that is, or I guess, is more of highest interest to both the patients and healthcare providers, and that is accessibility. And then I'll make some personal suggestions as to what is the potential way out. Okay. We all know that healthcare expenditure is extremely important, and it is important in a way that we have to spend enough money, not necessarily high, but just enough, because low health spending or insufficient healthcare spending will result in a lot of adverse effects to the overall society. For example, it can affect the availability of various healthcare services like radiotherapy, and it will also affect the manpower supply. But to the most important, to the cancer patients, the most important thing is if there is not enough healthcare spending, then there will not be enough things to prevent cancer. What I'm saying is that nowadays we always say early detection, but early detection means what? It's a lot of screening, and screening is expensive. We all know that, and therefore, if we don't have enough money to spend on prevention, then we will end up spending more money for treatment. So this is the importance of enough healthcare spending. Now, in terms of contributing factors of increase, we all know that healthcare is getting more and more expensive, right, all over the world. These are the contributing reasons. First of all, demographic transition of populations, from young to more aged population. I'll have a slide to show you, which is really this is really of worry in Malaysia. Change in epidemiology, availability of new health technologies, increased expectations from public with all this information that is so easily accessible. Distorted incentives, especially in the private sector, because you know how private sector reward their physicians. If you order more, you get more, and hospitals also get more. But this is clearly not the right way to provide incentives to healthcare professionals. And then from the government perspective, there's a misallocation of resources. As I just said, all over the world, not just Malaysia, people tend to spend more money at the tertiary, secondary or tertiary level. But in fact, it has been proven numerous times all over the world that primary care or prevention is the most cost-effective management. Okay, this is what I meant is worrying. This is the age structure of Malaysia. Let's see if I can use. Okay. This is the Malaysia age structure. Very recent, 2012 to 2022. Now, if you look at these three, the bars, the three different colors, the bright blue represents 0 to 14 years of age, and the black bars represent 15 to 64, and the gray bar represents 65 years and older. Now, what you look at here is, although it is not that clear, but if you look at the figure, over a period of 10 years, the age population, which is the 65 and older, increased by 40%. And then that 40% is from where? It's from here. It's from the working population. But if you look at it, the working population actually is shrinking because of the lower birth rate over the years. This is actually reflected in the shrinking blue bars as well. That shows the shrinking birth rate over the years. So just imagine in another 5 or 10 years, this working population, instead of moving back up, will continue to drop. And then this age population bar will continue to expand instead of shrinking. So an obvious question is, in 5 or 10 years' time, who is going to pay the tax if healthcare is totally relying on taxation? Right? So this is what I mean by this worrying. So somehow we need to come up with a solution to that. Now these are just some data to show that cancer incidence has been increasing over a period of about 15 years. See, it's all going up, except perhaps nasopharyngeal cancer has gone down a bit. In terms of age, you can see that both female and male, the incidence increases with age. Just look at this field curve. You can see as you go older, you are more vulnerable to cancer. Now, spending is going down, prevalence is going up, and then so is the cost of cancer care. Cancer treatment is also going up. For the past 15 years or so, this is, although this is American data, it's easily and acceptably widely recognized that it applies to other parts of the world. There's cancer drug costs a rise in 5% than other classes of medicine over this period. So what I mean is treatment of cancer is getting more and more expensive. And this is general healthcare expenditure as a percentage of GDP over a period of 22 years. Now, although most countries here are the so-called well-developed or high-income countries, there are a few that are considered as middle income or lower middle countries. So on the top is of course the US, which is the biggest spender, and then some European countries. Malaysia is here, the blue line, the blue curve. It is still going up. Nevertheless, it's still not quite up to what WHO recommends. So at the moment, we stand at 4.6 or 4.7 of overall GDP. WHO recommends at least a 5% in order to be qualified as a upper middle income country, which Malaysia aims itself to be. Okay, now going back to accessibility. Now in the last 5 decades, great progress has been made in the treatment of diseases, including cancer and other NCDs like diabetes, cardiovascular diseases, etc. And end up with substantial reductions in morbidity and mortality. I think this is very well recognized because in 5 or 10 years ago, if you have say pancreatic cancer, I mean it's really the end of everything. Nowadays, they got drugs for pancreatic cancer that would increase survival by at least 5 years. And these advances are not yet are not realized or enjoyed by many patients, particularly those in lower or middle income countries. So despite all these new drugs, the patients in most LMC or even middle income countries are not enjoying it. Geography and poverty are perceived to be the main barriers to access all this modern high-quality cancer care. Now, in Malaysia, we all know that the Ministry of Health has been working very hard in providing cancer treatment to patients. So these are a few types of co-payment. For example, they have this fixed percentage of co-payment. The patient pay a bit, sometimes drug company pays a bit, and then maybe top up by the government or etc. Or sometimes NGO will also chip in. And then next type of co-payment is conditional co-payment, and then or sometimes a hybrid of all this. So I think the government should be given credit for all this. So all this shared financing are in fact benefiting a few classes. Of course, the most important is the B40, right? And then other classes as well. Despite that, there are still gaps in the overall system. The first gap is there are always delays in formulary listing. So I mean, it's a well-known fact that when new drugs come out, despite they got registered in EU or in North America, it will take at least 2 or 3 years before they become available in Malaysia. Reason varies. I mean, budget is obvious one of the reasons, and then the procedure of bringing in the medicine and have it listed in local formulary, that's another reason. The second gap is limited access to high-cost medicines, mainly due to limited budget. The third gap is inconsistencies across hospitals and states. In Malaysia, some hospitals can provide certain medicine, some hospitals don't, even if they are all in the public sector. Reason is because different hospitals have different budgets. Some are more, some budget are more flexible, and therefore you go to them, and you'll be able to get some the latest, most innovative method. If some hospitals, their budget go fast, then they will either say no to you or refer you to somewhere else. So, budget, how to control budget, right? In the center is the dollar sign. So the obvious way to control budget is increase the income and cut down the outgoing. So how do we do it? This is what I suggest. So at the moment, Malaysia healthcare system is through a national health service, similar to the one in UK, where it is mainly funded by taxation. Government does all the pooling of fund and then start to purchase services from the public hospital. So this is how the NHS works. But then at the same time, there are other sources of income potentially, and one of which is called social health insurance. This is very popular in Europe, especially Western Europe. I'll talk about the details of it later on. And then out of pocket, although it's highlighted here, it is not the best way to finance healthcare because it will create a high degree of inequity. Because if everything is based on out-of-pocket expenses, then only the rich people can afford to get good care. All right. So highlighted here, but it's highly not recommended. So this is what Malaysia is doing. Population, the money, taxes go to the government, and then government send the money or allocate the money to public health facilities. This is too complicated, so I'm not going into detail. So instead, I want to touch on a little bit of this social health insurance. It's called the Bismarck model. Well, by the name, you know, this started in Germany. It can potentially be an extra source of generating revenue for the Malaysian healthcare system. This is basically a payroll deduction. Employees' salary gets deducted on every month, and then plus employer contributions. However, if this is the only source of income, that is from the employer and the employee, the long-term sustainability is not there, because if the economy goes down, then contribution will also be reduced. So that's why on top of this, it is to be complemented by general tax revenue. Therefore, government will need to play a role as well. Government needs to provide the backup. Under this model, public and private services can be integrated together. So this is a potential approach to improve accessibility and equity to patients and the long-term sustainability to the government. SHI is not without shortcoming. The strength is the source is risk pooling. It will be able to cater for larger populations. Overall, less expensive. It's more sustainable. However, there are challenges because the poor are usually excluded unless they are subsidized by the government. That's why in the earlier slide I said there must be a role for the government in here. Cannot just rely entirely on the employer and the employees. I'm going to skip a pocket. So another way to cut down the outgoing is by so-called value-based healthcare. Now at the moment, it's all quantity. But what value-based healthcare is a shift of paradigm from quantity to quality. In fact, it is not something. It's not anything new. It's part of the Affordable Care Act, or ACA, started by President Obama back in 2010, and that's why it is given the name Obamacare. So, just in a nutshell, value-based healthcare is a move from quantity to quality. So it's not a fee for service, but rather it's a fee for value. So you buy value and not just a service. So what is value? Value comprises a lot of elements. So this is the famous so-called Eastbourne value. Comprises things like quality of life, net cost, productivity, adherence, improving factors, production in uncertainty, etc., etc. So value is a multi-dimensional and multifaceted element. However, value-based healthcare is also subject to some so-called reservation, because value perception varies with gender, ethnicity, and socioeconomic status. So the simple example is perhaps the T20's value will be different from the B40s. And then the data system is fragmented. Financial risk will be perceived from the provider side, because for private hospitals, if quality is replacing quantity, that means their income is reduced. So they would have hesitation on this. Difficulty in outcome measurements. It's hard to actually measure how value-based healthcare, how to cut off whether it is working or not. And most important of all is we need a lot of capacity building. So, just to end my presentation, universal healthcare here in Malaysia is at stake due to scarcity in healthcare resources. And the way healthcare is financed must be restructured. Cancer care should be shifted from quantity to quality. Thank you for your attention. Thank you very much.